This recording will go over cervical neck pain, and we're going to skip to interprofessional collaborative care under the cervical neck pain section. Conservative treatment for acute neck pain is the same as described for low back pain, except prescribed exercises focus on the shoulders and neck. The physical therapists teach the patient the correct techniques for performing shoulder shrugs, shoulder squeezes, and seated rows. If conservative treatment is ineffective, surgery may be required, either minimally invasive surgery or conventional open surgery. One of the most commonly performed procedures is the anterior or lateral interbody cervical fusion. In these procedures, a titanium mesh device is implanted into the space where the cervical disc was removed, and several screws ensure stabilization. And the anterior is telling us that the surgeon will enter on the anterior side of the neck. The lateral procedure would be the lateral, on the sides. The first time I had a patient who had a cervical discectomy, I was really surprised because I was expecting their dressing to be on the back of their neck. But the most common procedure is an anterior procedure. So the dressing is actually going to be on the front of their neck. For this, if you think about this surgical procedure and where the surgeon's working, the big concern here is obviously going to be airway. We're worried about ensuring the airway stays patent, no problems with breathing. We're worried about swelling from the surgery, causing a narrowing of the trachea or windpipe. We're watching for any problems swallowing. And if we suspect there's any problems with the airway, obviously we'd call for backup. We want to review the post-op interventions as well as discharge teaching for a patient who has had the traditional anterior cervical discectomy and fusion. So post-op interventions, ABCs are our first priority: airway, breathing, and circulation. Check for bleeding and drainage at the incision site. Now remember, if it's an anterior procedure, the dressing's on the front of the neck there, they're laying in bed. But if they did have a lot of drainage, their dressing might not look super saturated if the drainage is seeping out and running behind their neck. So be sure to look back there as well. Monitor vital signs as well as neural status. Check swallow ability. Monitor eyes and nose. Assess the patient's ability to void, manage pain adequately, and assist the patient with ambulation within a few hours after surgery if able. In terms of discharge teaching, be sure that someone stays with the patient the first few days after surgery. Make sure they understand their drugs, how to take care of their incision. Make sure they understand any activity restrictions, including no lifting, no driving until the surgeon allows, no strenuous activity. We want to encourage the patient, though, that they do want to get up and walk every day, and remind them the reason why we're encouraging that. Helping to prevent clots, helping to keep the lungs healthy as well. We want them to be looking for any sort of complications that could occur, such as pain, numbness, tingling getting worse, or if swallowing becomes difficult, they should be advised to call the surgeon in those instances. And then finally, if they're prescribed to wear a collar, they would wear it as prescribed. And that is it for our cervical neck pain.